I wanted to echo Dr. Nazarian to thank both Alex and Ludmila, who apparently has just left my lecture, for inviting us here, and we're incredibly excited and enthusiastic about working with, forming a collaboration between our hospital and your hospital. Ludmila asked me to talk about two separate topics in one lecture, and I told her that I had two separate talks that were both an hour long each. So I'm excited to spend the next 3 hours with everybody in this room as we go through two separate things. One, ependymoma, which is, as you know, a very specific kind of pediatric brain cancer. And two, immunotherapy, which is an area that I particularly enjoy. We're going to go relatively quickly. I will try to speak slowly, although I know I speak quickly usually. Ependymoma is very common, and we often think of it as relatively easy to treat because if you do complete surgical resection and radiation, you can achieve cure. Although if those patients recur or relapse, then typically there isn't very much else that we can do to cure them, although they will probably live for many years, as opposed to many of our other kinds of cancers where once you have recurrence, you will probably progress and pass away very quickly. Most of these tumors in children are in the posterior fossa behind the brainstem, and we've really started to think about ependymoma not so much like medulloblastoma or leukemia, where you live or die, within a couple of years. And instead, for ependymoma, you will often have this chronic course of the tumor goes away with the radiation and the surgery, it comes back, you do surgery again, it goes away for some more months or a couple of years, it comes back. Eventually it will become lethal, but it's just a longer course. Ependymoma, as you know, can arise in really anywhere in the brain and spine. We think of it really in three separate categories now. One, supratentorial, above in the top part of the brain. One, infratentorial, where the posterior fossa is, the brainstem and the cerebellum, and then of course spine as well. The most recent World Health Organization classification changed how they looked at ependymoma very slightly. We already knew that ependymoma comes in different grades, grade 1, grade 2, and grade 3. What the WHO did here is that they actually added in for the first time a molecular finding, which we'll talk about later, to help us decide what kind of ependymoma a patient has. The other major point in the most recent World Health Organization update is a full discussion about the value of anaplasia, which we'll also talk about. When we talk about ependymoma grading, that's really the strength and the expertise of the pathologist or the neuropathologist. They'll take a look at the tumor, and if it looks very benign looking, they'll say that's a grade 1 or a really benign tumor. If it looks very angry with a lot of proliferating cells, they'll say that's a grade 3 tumor or an anaplastic tumor. And the classical ependymomas are somewhere in between. The problem has been that over time, we've noted, thank you, Ludmila, I was just going to use Javits. The problem has been that it's been really tough for us to decide whether or not anaplasia in ependymoma really makes a difference. It definitely makes a difference in some kinds of cancers. It hasn't seemed to be as clear-cut a difference in ependymoma. There's really been two major reasons for this. One is that the pathologist says this tumor is anaplastic, and then they give that tumor to the next pathologist, and that pathologist says this tumor is classical, there's no anaplasia there. And then it gives to the next pathologist, and they, of course, pick one of those two, and so forth. And so when pathologists review their colleagues' diagnoses of anaplasia, they will often change they'll change the anaplastic recommendation. Oh, I like Far Side cartoons. And so the point here is that, so these are pilots flying an airplane, and they are looking through the clouds, and they say, that's a goat. What's a goat doing up in the clouds? And they're forgetting that it's not the goat that they should be worried about, but it's actually everything around behind the cloud, obviously. Hopefully nobody here would be on a plane like that. So currently in today's world, everybody treats ependymoma the same. We do as best we can at a complete surgical resection, and we do radiation just to the sites of disease. Occasionally, there will be chemotherapy for some patients, such as very young patients who are infants, or other patients who we hope might benefit from chemotherapy, and we'll talk about whether that actually helps or not. The reason that surgery has been so important in every study that has looked at this is because when you look at both the progression-free survival and the overall survival, if you get it all out, you do so much better regardless of whatever other treatment you have. If you have an incomplete resection, so you leave too much tumor behind, then your outcome looks pretty bad in many series. With radiation, because again, that's part of what we do, we say that you can have a better radiation, a better event-free survival if you get radiated. Although there are some situations, there are many case reports where patients have been cured with surgery alone, no radiation given at all. So it does raise a little bit of a question about how important radiation is for us in achieving cure. But chemotherapy has been the most confusing part. We use chemotherapy for almost every kind of pediatric cancer. Why wouldn't we use it in ependymoma? There are a lot of data from both the US and the UK and Europe to show that it seems like chemotherapy doesn't seem to increase the survival of these patients. So you have an ependymoma, you get your surgery, you get your radiation. If you get chemotherapy, you actually may not survive any better than if you don't get chemotherapy. On the other hand, there's some patients with ependymoma that you give chemotherapy to and you see the tumor actively shrink. There's really not a better way of understanding that, at least for that patient, the chemotherapy was effective at killing at least some of those ependymoma cells. In infants, there are infants who are cured with chemotherapy alone. And then in several trials, there have been trials that randomize between radiation and chemotherapy or radiation alone, and they saw a benefit to chemotherapy. This was one of the trials in the US. It's a little bit of an older trial where where about half the patients had a gross total resection, and there was a good number of patients, and they had a lot of patients who actually had tumor shrinkage. When you actually looked at the long-term outcomes, it seems like for those patients who got a gross total resection and only radiation, that they did just fine. If you got a gross total resection and chemotherapy, you did about the same as the gross total resection. If you did not get a gross total resection, the chemotherapy didn't really help you very much at all. So that's been the status quo for the last 20 or 30 years for ependymoma treatment. Radiation and surgery, that's it, over and over again. As with many other kinds of brain tumors, we've had an explosion of scientific and molecular data from many authors who have looked at ependymomas, and we'll talk a little bit about some of their exciting findings. Most specifically, this is just one person's summary of both the molecular findings and all the clinical findings that we've noted. We're going to skip the spinal cords because the spinal primaries typically occur in adults, and you can tell because it's mostly adult man and woman here. We'll really look at the four groups: the posterior fossa group B, the posterior fossa group A, and the supratentorial YAP1 and relay fusion positive tumors. These subependymomas also can occur in children, but is pretty uncommon. And so ultimately we really have, out of these 6 different subgroups, we really only have 4 that we really see very often. So again, you can have a posterior fossa ependymoma that's a subependymoma, but we're going to ignore that for now. So what's the difference between a posterior fossa group A and group B tumor, other than some scientists telling us that they're different molecularly? Well, all you need to do is look at these 2 curves, and you can see that if you have a posterior fossa group B tumor, then your overall survival is above 90%. Whereas if you have a group A tumor, you really have only a 50-50 shot chance for cure. And if you have an event, these are event-free survival curves, where if you have a group B tumor, you have a better overall survival, and you're obviously event-free survival. It's not quite as high as the overall survival, but the difference between a group B and a group A tumor is quite distinct. So we tend to now think of these posterior fossa group B ependymomas as better than having a posterior fossa A tumor. And these are all ependymomas that are in the posterior fossa. We're just talking about those right now. The things that distinguish a group A ependymoma are this entity called a CpG island methylation phenotype. So Dr. Nazarian was talking about epigenetics and methylation. So you may also hear these tumors referred to as CIMP positive and CIMP positive tumors. Really what that does is it downregulates some of the tumor suppressor pathways by these epigenetic modifications. There are a lot of different alterations in the posterior fossa A tumors, but in general, somewhat surprisingly, their genome is pretty balanced. There's not a lot of translocations. There's not a lot of mutations. I sort of usually think of a cancer as being more aggressive if it has more mutations. But in this situation, it's the less mutated tumor that seems to be more aggressive. The posterior fossa B tumors have pretty good survival, as we talked about already. They actually have many more mutations, but most of those mutations funnel through something called the Notch pathway. We unfortunately don't have a lot of treatments right now that can attack the Notch pathway specifically. So far, we haven't really thought a lot about how to alter the posterior fossa B treatment, although we do know that they already do a little bit better than the other group. So as I said, the posterior fossa group A is a pretty genomically bland tumor. So if you look at all the different mutations, glioblastoma, as you might expect, is very high. Ependymoma is very, very low. Posterior fossa group B tumors also, again, have a lot more mutations than the group A tumors. Now, when we look at the supratentorial compartment, we really focus on two, the YAP1 component and the Rayleigh fusion component. And just like in the posterior fossa A and posterior fossa B, it depends what kind of molecular ependymoma you have as to what your survival chances are. This looks like near 100% survival, both overall survival and event-free survival for a YAP1 tumor. So this purple line is it's a blue line actually, but the blue line here is the YAP1 positive tumors. The red lines are the Rayleigh fusion positive tumors, which we'll talk about, and those guys have some of the worst outcomes for ependymoma. So suddenly, it's not just you have an ependymoma and how much do you get out and whether you radiate it, it's actually what kind of biology underlies that tumor. So the YAP1 tumors have an excellent outcome, and really the next step for them, which is being discussed now worldwide, is do we feel comfortable enough with YAP1 tumors to not even radiate those tumors at all, understanding that radiation can be a really bad player for children. The other tumors, the Rayleigh fusion tumors, are unfortunately the majority of the supratentorial tumors. So if you have a child with an ependymoma in the supratentorium, it is probably this kind of tumor, which is not good because this kind of tumor is tough to cure. This tumor really signals down to the NF-kappa B pathway. There are some drugs that target this pathway, and they're being slowly developed now to include in some treatment for ependymoma. So all the things that we've thought about ependymoma as being good or bad. We've thought that not having enough tumor out was bad. We thought not having radiation was bad. We thought chemotherapy might be helpful. So this author took a look at all of those tumors and then overlaid those with a molecular phenotype to decide which ones really seem to matter. So this 1q gain, which is a chromosomal aberration, which is seen most commonly in the Rayleigh fusion positive tumors, that's a bad one. That's probably one of the worst prognostic factors that we can see in these tumor types. Resection status remains bad. So if you have a subtotal resection, you take a 20% survival hit off the top of the curve, no matter what other treatment you get. Posterior fossa group A versus group B, as we just saw, seems to be quite bad, meaning that you would rather have a posterior fossa group B tumor. And then YAP1 versus, a Rayleigh fusion positive tumor versus another kind of ependymoma is also much worse. There are some things that we used to think of as very important that are probably not that important. So whether you have anaplastic, group 3 versus grade 2 is probably not that important. Whether you get chemotherapy doesn't seem to be very important. Whether you get radiation also doesn't seem to be important, and we'll delve a little bit more into that in a second. So we often think of young children as having poorer outcomes. When we control that for different kinds of tumors, it does not seem to be as important. So these are all children with posterior fossa A group tumors, and it seems like both their event-free survival and their overall survival is pretty good no matter what age they are. So suddenly maybe it's not so important that you're 2 and you have a posterior fossa group A tumor. Suddenly it's probably more important that you have a group A tumor to begin with. Same thing with group B tumors, both event-free survival and overall survival map almost identically, so age isn't really important in any posterior fossa ependymoma, it looks like. Resection status, is it really true that we need to be really aggressive with surgery? Surgery is really harmful sometimes, and especially in the posterior fossa, can attack the brain tumor, can cause cranial neuropathies. So it does appear that surgery remains very important in a posterior fossa group A tumor, meaning if you don't get a full resection, then your outcomes from both event-free survival and overall survival are much worse. And the same with posterior fossa group B tumors. So really for these posterior fossa ependymomas, we have to resect them. If you don't get it all out the first time, you should probably go back in again before you do any other treatment. If you don't get a gross total resection, it really doesn't matter if you do radiation, you probably aren't going to survive. Posterior fossa group B tumors also require resection. As you can see, there's a much better event-free survival when you have a gross total resection. Although overall, there was pretty good overall survival for patients who, of course, got gross total resections with or without radiation. over subtotal resections, of course. Radiation we talked about seems to cause a little bit of difference. So the blue line is no radiation, the yellow line is with radiation. So it seems like in the posterior fossa group B tumors, if you get radiated, you might do a little bit better, although it's not really that dramatic. So overall, what are the things to take away from this from an ependymoma? So resection status, important. It's been important, we thought it was important, it is important. Frontline radiation may not be as important for some tumors as we used to think it does. It probably helps in the posterior fossa group A tumors. It probably doesn't really matter for the posterior fossa group B tumors. But we do know that age doesn't seem to matter very much. I mean, I think that really when we think about ependymoma though, oops, I want to go back up. We have all this new biology and it's important. So it's actually important not just for research. It's important for us to know some of this information as soon as we meet this patient and start treating them, because it's going to tell us how important radiation is for them. It's going to tell us how likely it is that they're not going to do very well, which will change the way that you engage with both that patient and their family. But we haven't actually come up with a new treatment yet. So all the scientists have really been giving us clinicians a lot of new information, and yet we haven't actually started treating any of these patients any differently than we have for the last 20 years. Many of those reasons is because there's only about 200 new patients with ependymoma in the US a year, and probably 300 more patients out there in the rest of the world as well. And now we're saying that we can't just treat those patients by the way that we've treated all patients. We have to divide them up into 3 different groups based on whether they rise in the top of the brain or the bottom of the brain or their spine. And then we have to subdivide those groups again into 3 further groups. And so our numbers are getting really, really small. It's really a highlight. One of the really nice components of having to talk about ependymoma is that it's a highlight to all of us about the fact that the scientists are dividing our large tumor types into much, much smaller tumor types. And it's really changing our ability to do clinical trials because our numbers of patients are just too small. As sort of a segue to the immunotherapy talk, ependymoma has its own immunophenotype. What that means is that the way the immune system is active or repressive in ependymomas is different than it is in some other kinds of tumors. There are many different elements, including T-cell infiltration, the cytokines that the ependymomas both respond to or secrete, and the outcomes seem to actually change. So if you have one particular immunophenotype grouping, then you actually do seem to do worse than the ones who have a different kind of immunophenotype. And in here, this is not group A and group B that we were talking about before. This is one particular immunophenotype that changes. And so ultimately, I think that this slide really was just to show you that immunophenotype, the way your immune system reacts to your tumor, is going to be very important. So I'll try to speed up a little bit. No, I guess I don't have to. So I want to talk about immunotherapeutics. We've been fighting for so long with many different chemo regimens and surgeries and radiation and haven't made a dent in most of our CNS tumors for a long time. So immunotherapy has suddenly become the hot topic. Everybody's interested in this. It seems like it is changing the landscape of cancer treatment in a lot of different adult kinds of cancer. But we first have to sort of understand how the immune system works in order to really leverage it to help children with cancer. So the immune system, as you know, has both activating elements in our bodies as well as suppressing elements. And that makes sense because the immune system is important when it's needed to fight off an infection or to help heal you. Then it really needs to be upregulated. But if it gets upregulated as unchecked, then we have a lot of immunologic diseases like lupus or MS or rheumatoid arthritis. So the cells in the immune system each play a role in activation or suppression. So as we think about them, we think about the T cells and the natural killer cells as cells that are really the effector soldiers of the immune army, and the dendritic cells as the cells that sort of teach the rest of the immune system how to attack something. But there's a whole other set of immune cells that actually fights against the activating immune cells, regulatory T cells and MDSCs, and their whole job is to turn off the immune system and the immune response. And even on the T cell, so that's the difference between one type of immune cell versus the other type of immune cell. But even within the T cell, there are both activating and suppressing components. And so some of these we're very familiar with now because everybody talks about these, CTLA-4 and PD-1. These are antigens that suppress the ability of the T cell to attack anything. And they're activating antigens as well that can reactivate the T cell. There are a lot of barriers to immunotherapy being effective in the body against cancer, and especially within the brain. So one of the hallmarks of the way that we have thought about the immune system in the brain has been that the immune system doesn't get into the brain. Why have we thought that? Well, when scientists looked at mice models and they implanted a tumor into the flank and then they implanted a tumor into the brain tumor grew and the flank tumor went away, not because they gave treatment, but just because of the immune system in that mouse. Now it does seem like that there are a lot of different markers that tell us that the brain can be responsive to the immune system. We do have other barriers to continue to identify and to overcome, because there's a lot that goes into the immune system actually attacking brain cancer. First, the brain cancer pieces have to get out to where the immune system can see it so the immune system can grow strong. The immune system then has to somehow get into the brain, and not only get into the brain, but get into the tumor itself. The tumor, as most solid tumors, has its own ability to turn off the immune system. So one of the reasons that cancer arose is because it had been able to evade the immune system for a long time. And finally, even if there is a robust immune signature, immune activation in the brain, well, that's okay in the stomach, but it may not be quite as safe in the brain. So first we'll talk about the blood-brain barrier. So this has been a really tough piece of neuro-oncology treatment for many different reasons. From the perspective of the blood-brain barrier in the brain, the scientists previously, as I said, have really thought that the immune system can't get into the brain very well. And they derived most of that information from autopsy studies and preclinical studies. But when they cut into the brain and dissected, they noted that unlike the rest of the body, there weren't a lot of lymphatic vessels draining the brain. So that means that the vessels that are tasked with returning immune cells weren't in the brain, so it seemed reasonable to assume that those cells weren't in the brain either. The immune system requires antigen-presenting cells. They didn't find any of those in the brain. We already knew the blood-brain barrier was going to be an issue in terms of getting many things into the brain, and it seemed reasonable to assume that that would prevent immune cells as well. And again, as I talked about, the escape of the allografts, but for the scientists putting tumor cells into the brain itself. We know today, though, that that's not quite true. It's true the CNS is not the same as the rest of the body, but it's not immune. It's not immunologically completely distinct. So now we know that there are actually lymphatic vessels in the brain, and that antigens not only drain through the brain and through the olfactory bulb, but they actually traffic through the CSF. We also know, and we've known for a long time, that the blood-brain barrier is a leaky barrier when we talk about tumors, because the kinds of blood vessels that the tumors grow to themselves are not as intact as normal blood vessels. We can detect circulating tumor cells. So you have a brain tumor, and you can actually detect both those tumor cells in the serum of your blood, as well as immune cells that are active against tumor antigens. And there are a lot of different ways that white blood cells have of, even if there's an intact blood-brain barrier, of just trafficking their way past that. So I'm going to go very quickly through some of the major immunotherapeutic approaches. So we're most familiar with passive antibodies. These are all the medicines, the monoclonal antibodies that we always talk about. And those are technically all immunotherapy, because they're antibodies that are attaching to an antigen and causing some intracellular change, typically. BiTE cells are a kind of new antibody, which are engineered, and they're very exciting. They stand for bispecific T-cell engager. And basically a BiTE cell is these two pieces. And what their whole goal is to attach to something on the tumor cell and to attach to something on the T cell and just pull them together so the T cell can then attack the tumor cell. There are a lot of advantages to BiTE cells. They are small. So their penetration past the blood-brain barrier is good. Their penetration into tumor itself is good. These can be things that are off the shelf, meaning you can make a ton of BiTEs and then store them and then just give them to whichever patient seem to be good. And there's actually examples of BiTE cells being effective in glioblastoma. Cytokines, these are really old medicines as well. This is basically, you're giving the body some cytokines to sort of promote an inflammatory reaction. There are a lot of examples, interferon and IL-2, that have been used in different kinds of cancers. We don't really look at cytokines by themselves for brain cancer right now. They have been tried and have seemed to be just ineffective. However, they are very good partners with many of the other immunotherapy choices that we'll talk about, and the BiTE cells even that we talked about a second ago. This is probably one that when you think about immunotherapy, you think about adoptive lymphocyte transfer or adoptive cellular transfer. This is a very resource intensive. It's hard to do. It takes a lot of money and it takes a lot of time to generate these. But basically what happens is that you take the blood out of the patient that you're trying to generate the immunotherapy for. You also take the tumor out of that patient as well. And so ultimately what you will do is you will use the tumor that you've extracted to train the white blood cells that that person has had, and then you'll grow those white blood cells and eventually will give them those cells back again. The most obvious form of adoptive lymphocyte transfer are the CAR T cells. So everyone talks about these great CAR T cells. I know that they have been revolutionary in some kinds of leukemia, specifically those that have CD19 as an expression antigen. The CAR T cells are really, really interesting. Basically what they are, they're engineered to express this portion of the molecule, and that is designed to attack a particular antigen. So a CAR T cell does not attack just any tumor cells. It attacks the antigen that it's programmed to attack. There are some CARs that have a couple of these different molecules, so they can attack 2 different antigens at one time. But again, the goal is that they will bring the T cell that you've infused right into the tumor cell. CAR T cells, though, are no different than other adoptive lymphocyte transfer. They have to be generated from the patient. So you can't grab a patient, generate CAR T cells, and store it for the next 30 patients that have the same antigen. It means that for every patient, the CAR T cell that they get is their CAR T cell. So again, it's been highly successful in leukemia. They actually have to combine it with chemotherapy or some way to take out the host immune system, even though you're giving those immune systems right then as well. But it's also very expensive. Now, there's some really good preclinical data and some clinical data that CAR T cells can be effective in the brain. So we have mice here who have who just got nothing, and you can see as they move on that their tumor continues to grow. Others who get T cells, but these T cells are not CAR T cells, and maybe there's a little bit less growth, but it's still certainly there. And then you have the mice who get the CAR cells, and there's no question that the growth in this example shows that their survival and their tumor growth are both longer or less, depending. And this is just another graph of the same thing. The one element to look at for this is that what this blue line is that this line is a bispecific CAR T cell. So it's not just a CAR T cell attacking one antigen, it's a CAR T cell attacking more than one antigen. And so that will probably be the best way forward for CAR T cells. Now we have clinical evidence as well. This was from a New England Journal article that was published just under a year ago now. It was a 50-year-old with a glioblastoma, so something you typically think of as not curative. You typically can't cure somebody whose glioblastoma has come back. For this patient, he had a lot of different tumors, and they actually took out many of those tumors, but they left 2 behind. When they gave this CAR T cell, and this CAR was against an antigen called IL-13 receptor alpha, it was actually also a CAR that stimulated something called 4-1BB, which is a stimulatory molecule. So this was one of those bispecific CAR T cells. And you saw on this PET scan, you saw the tumors go down. On the MRI scan, the tumors got better. In the spine, also, the tumors got better as well. And these CAR T cells were not given through the vein. They were actually given straight into the CSF. Unfortunately, even though you saw these great responses, this patient eventually recurred, and then this patient passed away. So by itself, really exciting. Not curative yet, but certainly a great first step for CAR T cells in glioblastoma. There are certainly limitations to this kind of technology. Without the right antigen, or probably antigens, the CAR T cell just won't work. If you give a CAR T cell against a CD19 leukemia kind of antigen, but it's in a glioblastoma patient, as you might expect, it won't do anything. The other problem is that those antigens have to be present sort of all over the tumor, but definitely not on the normal cells, because if your brain cells express that antigen, that they're going to be attacked just as vehemently as the tumor, just as aggressively as the tumor. CAR T cells are big. They're full T cells, and T cells have difficulty getting inside of things. I just said that they can get into the brain, but that's only the first step. So once they're in the brain, they have to then go to the tumor, and once they're at the tumor, it's not enough for them just to be on the surface of the tumor cells. They actually have to get inside the tumor. And once they get in there, it is not a good place for T cells. Inside of tumors, there's no oxygen. There are a lot of cells that downregulate the immune response. So there have certainly been situations where you can actually track CAR T cells, and they congregate, they gather inside the tumor, but then they turn off and they don't work anymore. Ultimately also, these T cells are not long survivors. So you can give the T cells and they're going to die out after a few months. And then if the tumor isn't killed, then you either have to keep giving those T cells or find some other way to increase the durability of that response. Vaccines, that's a whole nother category. And I think some people confuse things like adoptive cell transfer and vaccines. The difference is in adoptive cell transfer, you're essentially giving an army of cells to directly attack the cancer. In vaccines, you're trying to stimulate the patient's immune system to generate that army to kill the cancer. There are definitely some trials that use both adoptive cellular therapy as well as vaccines. If you hear about dendritic cells or virally derived vaccines, then again, what those do is they try to stimulate the immune system against the cancer. This was just there was a news article several years ago about a poliovirus vaccine out of Duke and a patient with a glioblastoma multiforme. And you can see that this woman actually got this poliovirus and her glioblastoma shrank away to nothing. And there were several patients on that trial who had similar responses, and all but one of them have reprogressed at this point. So again, it seems like it's not quite the cure by itself yet, but it's certainly a great step towards it. And the idea for the poliovirus vaccine is it is a vaccine. They infect preferentially the glioblastoma cells. And while the immune system was not smart enough to attack the glioblastoma, those cells looked too much like normal cells to them. It could very easily identify infected cells. And so it found the poliovirus infection. The poliovirus happened to be in all the glioblastoma cells. So when it killed the viruses, it also killed the glioblastoma. And the last category is the one that I think most people think about now, which is immune checkpoint blockade. So these are the checkpoint inhibitors, the PD-1, the PD-L1, the CTLA-4 inhibitors. These are medicines. So these don't have to be given, you don't have to wait for 2 months while you generate the CAR T cell for this. You could just give a patient the checkpoint. Remembering that what the checkpoint inhibitors do is that they're a very normal pathway. They're a pathway that's supposed to be able to be turned on in order to turn off the immune response. Unfortunately, tumors are really smart too. So tumors many of them have found the way to turn on the checkpoint pathway, which then turns off the immune response. This has been an incredibly exciting component of therapy. The pharmaceutical companies that are based both in the United States and elsewhere have actually shut down entire wings of research so they can focus on checkpoint inhibitors. Their approval started with melanoma and then just exploded to many other kinds of cancers. So all these approvals are situations where there have been clinical trials to show that checkpoint blockade can shrink that tumor and help cure those patients. Metastatic melanoma is not brain cancer, obviously, but it's like brain cancer. You can think about how bad it is. It is often considered incurable up front. They die very quickly. Most patients die within a relatively short period of time, and they don't really respond to treatment very well. So this sounds very similar to many kinds of our cancers as well. This is something called a waterfall plot. So these are all patients. Each one of these bars represents a patient who received a checkpoint inhibitor called pembrolizumab. And each one of these patients had this really aggressive form of melanoma that should have killed them in a year and should not have responded to any treatment based on everything we know about it. And this line is the 0 line. So this is where they all started. This is where their tumor started when they first started taking the medicine. And as you can see, most patients had either 100% shrinkage or very significant shrinkage to just this medicine alone. So suddenly, the immune system has been able to turn on and to kill this cancer in a way that nothing else has been able to do before. This is why the industrial complex has really started to focus on this. This is a big moneymaker for them now. In brain tumors, there were 10 patients with a glioblastoma in a trial that used checkpoint inhibitors, and one of those patients had a partial response, which remember means more than half of that tumor shrank away. This is another example of a patient who had gotten radiation, had a recurrence, and you can see the recurrence of tumor here, and got nivolumab, which is another kind of checkpoint inhibitor, and suddenly those tumors shrank away. So all those questions we had about the ability of the immune system to get into the brain don't seem to be applicable here. We think that checkpoint blockade works very well if you have a lot of mutations, and that's why this stands for biallelic mismatch repair deficiency. So these are patients and families who have a congenital disorder in their ability to repair mistakes in their DNA replication. So it makes sense that these patients have lots of mutations. They also have lots of cancers. And if they have cancer, their cancers have lots of mutations. This is an example of a child actually who had a glioblastoma who received nivolumab and responded very nicely to it as well. We'll talk more about checkpoint inhibitors in a second, but really just to remember that no therapy sort of comes free of cost to the patient. And I'm not talking about money, I'm talking about the side effects. So pretty much anything that you can think of from an inflammation standpoint, a disorder, any itis, pneumonitis, thyroiditis, colitis, all those things can happen with checkpoint inhibitors or any other immune system immunotherapy. But it is hard for us to actually translate immunotherapy that has worked in the body into the brain, and there are a few reasons why. So some questions that we have are, which patients are the right ones to try immunotherapy in? We just talked about how few patients we have, but now we have to talk about not whether they have ependymoma in one of the 9 subgroups. Now we have to talk about what kind of immune system does their ependymoma have. We don't know whether the molecular phenotype means anything. If there's a side effect from the medicine, that is probably going to be worse in a brain tumor than something else. And we actually don't know many other questions. We don't know how to combine checkpoint inhibitors or other immunotherapy yet. I'm going to talk about this entity of pseudoprogression that Dr. Nazarian mentioned before as well. We don't know what the right dose is, because most of these medicines, unlike chemotherapy, for chemotherapy you give more and more, you get sicker and sicker. For immunotherapy, you give more and more, and some patients you give a little bit and they get very sick, and some patients you give a lot and they don't get sick at all. So this is one of the biggest problems with immunotherapy in the brain. Some people call it pseudoprogression, others call it tumor inflammation. This is a diffuse intrinsic pontine glioma. It's that tumor that Dr. Nazarian was talking about. This is where it was when it was diagnosed, and this is where it was after radiation but before vaccination. So it looked like it was getting a little angrier, but it wasn't doing anything very much. Then you give this immunotherapy. This is a peptide vaccine, and they gave this immunotherapy, and suddenly the tumor got much worse. So this patient started not being able to talk or swallow. They couldn't walk. They were in the ICU. Part of their face wasn't working. One of their eyes wasn't working well. And this was 3 months or 4 months after the vaccination. So any situation in any medicine, you would say, this patient is progressing. This is all tumor, and we're in trouble, and we probably don't have anything else to help you. They did nothing else. And just 1 month later, they gave no other medicines, no radiation. The MRI improved significantly, and the patient was back to baseline. So all of those problems they had were just gone. And so ultimately, in retrospect, you can say this wasn't actually progression. This was actually something else that looked like true progression clinically. It looked like progression on the MRI scan, but it was probably a response to the immunotherapy. That happens in other situations as well. I'm going to talk about these MMRD patients again, because these are the patients that respond very well to checkpoint inhibitors. This was the case of a patient, though, who had a glioblastoma. They got an infusion. They had massive swelling that improved a little bit on steroids. They went to the ICU for a few days. The second infusion, they had a seizure. One of their pupils blew, which means that it wasn't reactive anymore. The patient was unresponsive, so they actually took a bone flap out to relieve the pressure, and they kept going. Now that patient got a little better there, but after the 6th infusion, the swelling was just too great, and so this patient died from the swelling. That's really important to know, because these mismatch repair deficiency patients seem to have about an 80% response rate to checkpoint inhibition, which means that this patient probably wasn't progressing from tumor progression. This was probably because their immune response was too strong. And so it had too many immune cells coming in to attack the tumor. And when that happened, the patient just didn't have enough space in their brain to survive. This is actually not brain tumor. This is a melanoma graph, but it's something that I think is very indicative. So in this graph, they took all these melanoma patients who responded to checkpoint blockades. So that means that every person that's included here actually had benefit from checkpoints. Now, this is pretty clear. So for these top 2 graphs, if you started here and you got your checkpoint inhibitor and your tumor shrank, well, that's a success. So there's no question there. It'd be very easy to see. If you started here and you grew a little bit, but less than 25%, and then you shrank, well, that would also very clearly be a success and easy to see. The problem has always been in these 2 groups. So these, remember, are patients with melanoma who eventually shrank from checkpoint blockade. This patient's tumor doubled in size. So they took their checkpoint blockade, it doubled in size, they kept taking their checkpoint inhibitor, and it eventually shrank down to almost nothing. we would miss this signal because anytime we saw this in a clinical trial, we would kick this patient off the trial, we would say that he's progressive, and then they'd go on to some other treatment. This is a different situation where the tumor as a whole did not grow too much, not more than this dotted line, but suddenly there was new disease that we saw, metastatic disease. So whenever in a clinical trial we see evidence that the treatment is not helping prevent tumor growth, and one of those criteria are if there's new disease growing suddenly, we would say this patient should also be off the trial because now we see metastatic disease where there was none before. But these guys kept going on the medicine, and they also shrank down both their metastatic disease, which completely resolved, none was seen anymore, as well as their baseline disease too. So in these two situations, a normal clinical trial design would have missed these signals. So we would have tried the medicine and we would have thrown it away because we thought it wasn't helping. That's all because of this entity of pseudoprogression. There are some things that can sort of tell us whether something is pseudoprogression. If you stick a needle into the tumor or take some tumor out, you might see more T cells than you would expect in the tissue, and you'd say, well, that seems like that's inflammation rather than tumor growth. There's some MRI changes that sort of suggest that it could be more likely to be inflammation than the other. And sometimes you can tell it's pseudoprogression if you give them some medicines to help with inflammation and they get much better. However, the problem is there really is, no matter what any doctor or radiologist or pathologist says, there's actually not a way to tell whether somebody is having tumor inflammation or pseudoprogression or having true progression. The only way to tell is with time, because the people who are truly progressing will eventually progress and their tumor will grow and grow and grow, and those who are having only tumor inflammation will eventually get better. It makes it really hard for us. So now we don't know when we stop immunotherapy. If we have temozolomide or we have an EGFR inhibitor and it's not working, then we know, and we'll stop that medicine and try something else. With immunotherapy, and this is not just the checkpoint inhibitors, but with immunotherapy, we simply just don't know exactly when something is pseudoprogression versus tumor inflammation. I'm going to pass that. I do like this slide though, because the idea that pseudoprogression is bad is really an idea of perspective. So, this is a cartoon, and here's a guy who's been on a boat for a long time, and he sees an island, and he says, "Land, hooray!" And this guy who's been on the island for a long time sees a boat, and he says, "Boat, hooray!" So they have different perspectives of the same event. Pseudoprogression is bad because it confuses us. It makes it hard for us to decide whether medicine or treatment is actually working or not. It's also bad because it hurts the patient. It makes them have new neurologic symptoms, and as we saw, it could actually kill them. But pseudoprogression is actually also good, because what that really means is that you have a successful immunotherapy that was actually able to send immune cells into the tumor to attack it. If there's no pseudoprogression, then it's a concern because maybe your immunotherapy just isn't doing anything at all. So what do we do with steroids? We all love steroids in neurooncology because it helps us. It helps the patients feel better. It does have a lot of side effects like making them eat too much and making them angry and changing their glucose and their blood pressure. But the steroids do something bad to the immune system. Steroids suppress the immune system. So if we are using steroids in our brain tumor patients and we are also trying to use immunotherapy, we are probably making the immunotherapy not work simply because we're giving the steroids. This was a melanoma study again, but this was one with brain mets. These patients didn't have any steroids, and these patients did. And the disease control after a few months of treatment was much better in those patients without steroids. And this has actually been seen on a lot of immunotherapy protocols. So most immunotherapy protocols will say no steroids. That may be okay. You don't need steroids if you have skin cancer. That's harder for brain cancer because if you have pseudoprogression or swelling, or if you have a tumor that's growing and one that you think you need something new like an immunotherapy, then that patient probably also needs steroids because that patient probably has new deteriorating or worsening symptoms. However, it's something that we have to be very careful about doing. It'd be much easier if we could just measure how well the immune system was working. And so there are lots of questions about how to do this. Dr. Nazarian talked about ctDNA. Really, the problem is that unlike a melanoma, a skin cancer, where you could just take a little piece of the skin cancer every time you needed to check, we can't do that with brain tumors. So what we've tried to do is just draw blood. At least we can draw blood. Maybe we can see something there. In the blood, there have been a lot of different tests that have been taken, some which seem to be very helpful. So as we talked about, if you have a lot of mutations, then maybe that's a correlate to tumor response. If you have a lot of inflammatory cytokines, maybe that tells you the immune system is awakening and is really being helpful. So there are a lot of different correlates that we are drawing now in our immune trials, but the more you draw, the harder it is for the patient, the more expensive the trial gets, and we don't know which ones of these are most important right now. So I wanted to talk about the PD-1 story because, again, that's been something where you've had a lot of success. Not as much in the brain yet, but it's coming, I think. So PD-L1 is the antigen that's on the actual T cells that turns off when you have when you engage this system. And there's no question that if you have PD-L1 positivity, so if you use a stain and you see it on the cell of your tumor cells or your white blood cells, that you will probably respond to PD-L1 blockade. Those people who are PD-L1 negative did not respond as well as those who did. That's borne out in virtually every checkpoint inhibitor trial there is, which is that if you have PD-L1 positivity, you do better than PD-L1 negative. There are problems with PD-L1 as a biomarker, though. There are a lot of patients who, this is only 39.3% response. There are a lot of patients who have PD-L1 positivity that don't respond. And then there are some patients who don't have PD-L1 positivity who do respond. There's also a couple of things we'll talk about, including the test variability and the sampling heterogeneity. So sampling heterogeneity is important. So this is obviously one tumor, and we talk all the time about how a tumor is not the same from one site to the other. That actually holds especially true for PD-L1 expression. So these are two places that, to my eye, look, they're about the same color, they're clearly the same tumor, but when you stain them with the same antibodies, and there are two antibodies to PD-L1 that they tried, this section of the tumor is negative. So you would say this person should not get a checkpoint inhibitor because they're not going to respond. And this section of the tumor is very positive. So you would say this person should get a checkpoint inhibitor. So much of your testing is going to depend on what part of the tumor you get the tissue from. And this holds even more true in the brain tumors, where you sometimes just get one of those. You don't get the option of testing several places in the whole tumor. You just get a small part, and that's all you get. And you may draw the wrong conclusions if you're using PD-L1. The mutational burden was one that we talked about as well. So we think that checkpoint inhibitors, that tumors that have a high mutational load respond better to checkpoint inhibitors and other immunotherapy. Here we see that those patients who had a lot of mutations in their cancer did much better than those patients who didn't have a lot of mutations in their cancer. There's a problem with this too, in that there are some cancers that are very responsive that have very few mutations. And ultimately, I think that what we are coming to understand is it's probably not important how many mutations you have or whether you have PD-L1 positivity or not. What you really need is you need the right mutation. You need that one trigger that the immune system can see and respond to. If you have a lot of mutations, the chances of you having the right one, whatever the one thing is for the immune system, are higher because you have a lot of mutations to choose from. It doesn't mean that if you have only a few that you won't possibly have the same number there. And that's good for us because this is just a mutational spectrum for tumors like melanoma. We've talked a lot about melanoma because melanoma seems to be very sensitive to lots of different immunotherapy. It happens to be there at the top end of the spectrum. So they have 10,000 mutations, much more than any of the pediatric tumors. So pediatric tumors down here, pilocytic astrocytoma, AML, ALL, medulloblastoma, neuroblastoma, low-grade glioma, these guys have much fewer mutations than these guys do. And so it's going to be a little bit harder for us to design the right kinds of immunotherapy for our children versus the adults who have had some success already. I always like this story. So this is a bacteria, and I'll tell you why I like this story. This story is just to highlight how little we actually know about how to optimize our immunotherapy, how to make our immunotherapy better. So this was a lab that actually took mice, and you can order mice in the US at least from a couple of different places. So these are the mice that had the exact same genetic code. So these are engineered mice. And they took these mice just because they just needed some mice. And they just injected some cancer, some melanoma, it turns out in this case, into the flank of the mice. So very similar case. Actually, they just did one from the Jackson lab probably first. And then they used checkpoint blockade. And in one set of mice, they saw the tumor totally gone. It completely disappeared. And the other set of mice, it actually didn't do anything. So the checkpoint inhibitor was given here. And in these mice, the tumor kept growing. Now remember again, there was no difference. It just happened to be, they saw this, they did this experiment, they saw this response, they said, what a great response, let's do it again. The lab technician happened to order the same mice just from the different lab. They did the same exact experiment. It did nothing. The checkpoint inhibitor didn't do anything. And again, these are very similar mice, the exact same tumor. I don't know if this was intentional or not, but they ended up co-housing these mice. So probably they threw some of these mice in the same cage, both the ones who had responded to the checkpoint and ones who didn't. And suddenly the ones who had not responded to the checkpoint inhibitor responded quite nicely. Well, that was very confusing for them. So what they did this time is they did the exact same experiment. They took mice now from the two different labs. They stuck the tumor into the flanks. They actually took the poop from the mouse that had responded, and they fed it to the mouse who hadn't responded. And suddenly both mice responded to the checkpoint blockade. So it wasn't necessary for them to live together. It was just necessary for the mice to eat each other's poo. So then when they looked at that stool, they isolated this bacteria, which is called Bifidobacterium. And instead of giving the stool, they actually took these mice that weren't responding here. They didn't feed them poop, they fed them this bacterium, and suddenly those mice responded as well. So this is just illustrative. This just demonstrates that we don't really know very much about immunotherapy. This thing called the microbiome, what bacteria are in the intestines of mice that are otherwise exactly identical, may actually change the way we understand how immunotherapy works. If these were kids instead of mice, although we wouldn't feed poop from one kid to the other. But if we had this child and they just didn't happen to have the right bacteria, we would have said this immunotherapy, checkpoint blockade, doesn't work. So we have a lot to learn about how to make immunotherapy stronger and better. So how do we go forward? I just illustrated a bunch of challenges that we have for the CNS. So combinations are going to be important. So this is not brain cancer, this is HIV. And so this blue line represents the deaths that happen from HIV-infected individuals. The red line is the new medicines that have really revolutionized HIV treatment. So if you were to remove these and just say these are the deaths from brain cancer and these are immunotherapy, at one point suddenly the deaths from the treatment, the deaths from HIV dropped. It just plummeted 30 points. What happened here is that they started combining their different protease inhibitors and HIV medicines together. Combinations are going to be much better. And there are a lot of combinations to consider with immunotherapy. We use irradiation all the time in brain tumors. There's a thought that radiation actually helps immunotherapy by killing the tumor cells, by killing the local regulatory T cells, and releasing antigen for the immune system. There's no question that immunotherapy together may be effective. That patient who responded to the CAR T cell had an immunotherapy that was actually two immunotherapies. It was two CAR T cells combined into one. In the melanoma world, they are using both CTLA-4 and PD-1 checkpoints, so they're combining different checkpoint inhibitors and seeing much better effect and much longer lasting effect as well. We talk about giving these T cells to patients, but sometimes that doesn't seem to be enough. And that may be because the T cells actually work and the right antigen is on the tumor, but when the T cell gets to the tumor, it turns off. And one of the ways that turns off is probably the checkpoint system. So combining checkpoints or other medicines along with T cells is probably going to be helpful as well. We all use chemotherapy. And it seems like chemotherapy wouldn't be very smart to use with immunotherapy because just like steroids, chemotherapy hurts the immune system. So you want the immune system to be strong, so it will attack the cancer, but you're hurting the immune system with steroids or chemotherapy. But there's actually data to show that if you time that chemotherapy just right, that it will actually make the immunotherapy stronger by taking away some of the other regulatory cells that would otherwise turn off the immune system, and probably by just making the body think it's got to bolster its own immune system. So you give chemotherapy, the body says this immune system goes down, it releases a bunch of cytokines to try to stimulate growth of its own immune system, and if at just the right time you also give T cells, then probably it's going to be even stronger than just the immunotherapy by itself. So combinations will be one way forward. Anti-angiogenics like bevacizumab seem to have a complementary role to immunotherapy. It is not only because the immunotherapy penetrates the tumor better, it also is because VEGF is an immunomodulatory molecule. And that's something else, is that as we learn more, suddenly every medicine seems to be immunomodulatory and every cytokine is more immunomodulatory. What that means is that everything that we've thought about the body right now so far, the tumor, what's around the tumor, the normal body cells, they all affect the immune system one way or the other, and the immune system interacts with them in ways that we don't fully understand now. So the last thing is that we really just have to work together. So one of the reasons that Javed and I were so excited to come here is because it's an opportunity. We just got done for Ependymoma, realizing that we're talking about very small sets of patients, and in immunotherapy that's an even smaller subset of patients. And if you use the wrong immunotherapy in the wrong patient, it's gonna not work. So there are lots of us across the world. You know, if I had more time, I would have dressed them differently and put different hats on them. But there are lots of us around the world. And so far, different labs, different universities, different countries have been trying to do the same thing as each other, but separately. So what we need to do, and what is starting to happen now, is that we're coming together in large groups. This person is not coming together. This person is just off on their own. But everybody else is working together. And you can even envision this to be, you know, people here in this institution and people at our institution and other universities as well, working together. And there are a lot of different ways, I think, that we can collaborate to try to make immunotherapy better, to work on ependymoma and other brain cancers. The conclusions are really that immunotherapy is a wave. It has been around for a long time. There have been excitements in past decades, but this is an unprecedented development, meaning that we now see that immunotherapy can be effective where nothing else has been effective before. In pediatric brain tumors, there are a lot of barriers. We don't really know how to do that. We're trying a lot of things, CAR T cells, checkpoint blockade, combinations with other treatments. But there are barriers both to make it work well, and there are barriers because we don't want it to work too well. We don't want to cause too much pseudoprogression because that will be dangerous for the patient. But efforts by us and by other groups that are really working together, and you guys and everyone else in the world, all those efforts really make me think that with combination therapy, that immunotherapy is really going to be the way that we're going to revolutionize the treatment for all these kinds of cancers. That's it. Thank you so much.
Thank you, Jean, for excellent presentation. Are there any questions to Jean? Okay.
Thank you very much for the lecture. A question about patients with mismatch of brain deficiency. They can have at one moment different tumors, for example, brain tumors and colorectal cancer. And is there any experience when such patients were treated with nivolumab, for example, and have positive response in all tumors?
Yeah. It's a great question, thank you. So the question was, in these mismatch repair patients, they are prone to developing mutations, so they're prone to develop cancers. Their cancers have a lot of mutations, but they're not just prone to developing one cancer at a time. Often they have cancer all over their body. The checkpoint inhibitors, there has been experience using those. They seem to see response. If you see a response, which you probably will, you will probably also see a response in all the sites of disease, interestingly. As I said, it's if there's a brain component of that, then it can be a little bit dangerous. Although if there's no other choice, then you have to go forward because that patient's just going to get sicker and pass away otherwise. Many of the strategies that people have used is to debulk the tumor in the brain so that there's room for swelling to occur. And the other strategy, which is now in clinical trial, but I bet will be the best strategy, is to give them the checkpoint blockade very early when they don't have active cancer growth. So not to prevent cancer from forming, but when you think you've controlled the cancer, to then give the checkpoint blockade, because there's also no question that much like chemotherapy, immunotherapy really works best when there's only a little bit of disease left, rather than having large amounts of disease.
Может быть, еще вопросы есть, допустим, по первой части лекции. В таком случае поблагодарим докладчика. Юджин, thank you so much for the outstanding talk. Thank you.